Our next speaker is Dr. Jerry Fahrni. He is the product manager at Talyst. Dr. Jerry Fahrni has been a licensed pharmacist in California since obtaining his PharmD degree in 1997 from the University of California, San Francisco School of Pharmacy. He has over a decade of experience as a clinical pharmacist in various acute care settings, including pediatrics, as well as several years in critical care medicine. He has been involved in several acute care initiatives over the years, including pharmacy automation and technology, smart pump technology, CPOE, or computerized provider order entry, and BCMA, barcode medication administration. Dr. Fahrni's areas of interest include pharmacy automation and technology, informatics, healthcare integration, mobile healthcare, and the application of social media to pharmacy. Dr. Fahrni will talk about the evolution of pharmacy practice in the age of information. In this presentation, he will outline key changes to pharmacy practice along with examples of new automation and mobile technologies that illustrate these developments and implications for the future of pharmacy practice. Please welcome Dr. Jerry Fahrni.
Good morning, everybody. It's always nice to be here in sunny Southern California. It gives me another excuse to go visit my daughter who's attending school just up the road at UCLA. Although apparently in this area, a few miles up the road means a few hours in the car. But today we're here to talk about pharmacy. There we go. Pharmacy's been around for a long, long time. If the history books are to be believed, it was carved out of medicine sometime around 1240 AD, and public pharmacies started to appear in Europe sometime in the 1700s. And then it made its way over into the United States, and it was kind of legitimized and formalized with the first school of pharmacy set up in Philadelphia in 1821, followed shortly thereafter by a school of pharmacy in Boston, Massachusetts in 1823, and then New York, Chicago, Baltimore, so on and so forth. And to keep things simple, it pretty much continued that way until the idea of clinical pharmacy was introduced. We seem to be having technical malfunction. It's not seeing it. There we go.
Did we?
I don't know.
That's not working?
It is now. Okay, here we go. So that was until the idea of a clinical pharmacy model was introduced sometime in the mid-70s. And of course, the idea of that is to take the pharmacist expertise in medication therapy, and you push that out towards the patients, and you get them involved with the physicians and the nurses and things like that. There's been a lot of studies done to show the benefit of getting a pharmacist out of the pharmacy to the bedside. There's data to suggest that pharmacists can improve the quality of life of patients. There's also data out there to show that pharmacists can improve morbidity and mortality. And there's even data out there to show that pharmacists can save healthcare systems money. As a matter of fact, it's come to the point now where when you see one of these studies, you kind of roll your eyes, because we do all these studies and we collect all this information, and then we really don't do anything with it. So there's only been one study, though, that I'm aware of that has ever taken a look at bringing a pharmacist back into the pharmacy as part of the medication distribution process. And that was a paper in 2004 in pharmacotherapy by Bond and colleagues. And what they did is they took a look at 5 core clinical pharmacy functions. Drug information, management of adverse drug reactions, management of drug protocols, and you've all seen those, management, please manage vancomycin or gentamicin or whatever the case may be. Medical rounds, and the last one escapes me. But what they did is they took these things and they looked at them against several criteria, such as how they affected morbidity, what effect they had on the drug cost, the total cost of patient care, length of stay, and medical errors. And the authors concluded that basically if you implemented these 5 core clinical practices and you gave the pharmacist time to do it, and you decentralized them to the floor, pretty much universally across the board, there was a positive outcome. But unexpectedly, if you brought the pharmacist back into the pharmacy, not only didn't it show a positive outcome, it showed a negative outcome. So when they brought the pharmacist back into the pharmacy as part of the medication distribution process, they actually found an increase in errors, medication errors. I'm not quite sure why that is. I don't know that anybody's ever taken a look at it, but we don't want to take a look at that, right? So what it's done is it's had this big push in the practice of pharmacy is to get pharmacists out of the pharmacy, but we've actually been really bad at getting this done. To say that pharmacists are part of the clinical practice model is inconsistent at best. You know, it's all based on how big the facility is, whether it's an academic medical center or not, you know, where the practice site is. So ASHP, which is the American Society of Health System Pharmacists, is probably the biggest voice for pharmacy in the area of practice today. And they took a look at this back in 2010 and they realized that we were just kind of spinning our wheels. So they decided to get something together and attack it from a more formalized process. So they came up with something called the Pharmacy Practice Model Initiative, or the PPMI. And what this did is this brought some of the best and brightest minds in pharmacy together by invitation only. I was not invited. In 2010 in Dallas, Texas. And the result of this PPMI was this huge list of recommendations of all the things that pharmacists need to do to advance the practice of pharmacy in the next decade or so. It include, you know, automation, getting technicians involved, and all that kind of stuff. But the nuts and bolts of it is we have to utilize pharmacists as direct patient care providers. But we really don't know what that looks like, right? And there's a lot of barriers in the way to getting pharmacists out of the pharmacy and out to where they can do the most good. It's interesting because does anybody know what the biggest barrier is? Okay, the biggest barrier is regulatory hurdles. You betcha. The regulatory agencies have been unwilling to change the rules that govern pharmacy as fast as pharmacy is changing. So for just 1 minute, we're going to assume that there's no regulatory hurdles. I actually have trouble saying that with a straight face. But I live in a fantasy world. It's my fantasy world. I'm happy there. So we're going to assume that there are no regulatory hurdles that have to be overcome in pharmacy. So it boils down to 2 questions. So how do we make it happen? How do we get pharmacists out of the pharmacy? And once you do that, what do you do? It's a good question. Well, the first question is super easy, right? We get there by automating. I mean, if you take a look at it, if you look at the automation and the technology that we have today, it's much better than what a human being can do. If you break pharmacy down to its basics, it's a logistics problem. It's how to get medications from point A to point B safely and effectively. The heavy lifting, the clinical decision support, the allergy checking, the drug-drug interaction checking, the lab checking, deciding on what therapy to use, working with the physicians and nurses to get the therapy right, that's all done before the drug is picked for the use by the patient. And let's face it, robots and machines are much better at that than we are. They don't get tired, they don't call in sick, they don't need breaks, they have no bias like humans do. Humans are subject to checking bias and all kinds of weird little things. And let's face it, if it's installed and it's implemented correctly, robots really don't make mistakes. And I was able to witness this firsthand last year. I was in Baltimore for ASHP summer meeting, and I had the opportunity to visit a long-term care pharmacy there. And this particular long-term care pharmacy services about 10,000 long-term care beds in the greater Baltimore area. And they had spent a lot of time, energy, and effort automating the entire process, distribution process from the back door to the time that the medication reaches the nursing home. It was really quite an impressive system. The gentleman who was giving us the tour, he bragged about the fact that they were able to lay off 5 pharmacists when they got this system up and running. You know, I was injured, right? deep down, I was hurt. But when I watched the machine work for a little while, I realized it wasn't a problem with the automation, it was a problem with what the pharmacists were doing, right? If you can be replaced by something that's a vending machine, then that's your fault. And, this machine had been up and running for approximately 18 months without a single scheduled downtime and without making a single error to date. You can't say that about a human being. You would be frightened to know how many errors occur in a pharmacy that are found, but you would probably be more shocked to find the ones or to hear about the ones that actually make it to the patient. I mean, statistics alone tell you that you're going to make a mistake, it's going to get to a patient, and there's even a certain percentage of those that are going to cause some kind of harm and nobody will ever know. So if you were to walk into a pharmacy today, you'd be surprised at what you see. We utilize a lot of technology. You know, I put this barcode up here, and it's kind of funny, right? Barcodes have been used in grocery stores for about 40 years, but they're new to healthcare. We only have about 50% of the pharmacies in the United States using barcode technology, but it's there. We're starting to see use of RFID technology, which is radio frequency ID. That gives us real-time information where we can track a drug through a hospital, and it can give us feedback on where it's at and what it is. We use automated carousels for storage. The carousels save us a lot of space. It throws things like alphabetical order out the window because it tells you where the drug is. We use locked and automated storage cabinets that make use of biometrics and cameras and transactional stuff so that we know where a medication is, who's been in there. And that's for obvious reasons for controlled substances. We want to track that very closely. And we also use quite a bit of robotics. Robotics is used both in kind of the general pharmacy area as well as the IV room. And there was an uptake of the use of robotics in healthcare probably, I don't know, about a decade ago. And what happened is we found out that they weren't the panacea that we thought they were. And that's simply because they weren't mature enough yet. You know, they didn't do exactly what we wanted them to do, and we weren't getting our return on investment. So you've seen kind of a dip in the interest of this kind of technology. They're very expensive, and what we found was maintaining them was difficult. It was labor intensive, it was expensive. But what you're seeing now is more and more advanced robots. I think they're still probably a decade away before they can actually replace a human being in a pharmacy. And that's without making any kind of decisions, right? Just repetitive motions. The other thing is that we have to get away from duplicating these, right? These are terrible things for doing repetitive tasks. The place that the robots make the most sense, in my opinion, is it makes sense in the IV room. And the reason that is because that's where errors can be most costly. And it's also where people are exposed to things such as chemotherapy. By putting a robot in there, you eliminate that. You also eliminate that repetitive injury type of thing. Telemedicine has become popular off and on for the past few years, and this is one of those regulatory hurdles. I told myself I wouldn't mention that, but I did. We use telepharmacy to not only communicate with physicians and nurses, but we use it to communicate with patients. Patients that may not have access to a pharmacist in remote areas. And we also use it nowadays to monitor technicians who are in remote locations, whether they're making IV products or whether they're in a satellite or something like that. And dispensing technology, any nurse in here, they know exactly what this stuff is. Automated dispensing cabinets have been around for a long time. By the way, when I came out of pharmacy school, I was told that automated dispensing cabinets would put pharmacists out of a job. Didn't happen. But this gets the medication near the patient, controlled access, decreases turnaround time. It's all good. But we've also started to take this technology and we've put it in outpatient spaces. We've put it near urgent care centers. We've put it near emergency rooms. And it sounds kind of counterintuitive to do that, but what you do is you take a patient that potentially in North Dakota has to drive 20 miles to a pharmacy to get their child a prescription. You know, that's, and they've just been in the ER for 4 hours, they're unhappy, the child's unhappy. It makes more sense to put your top 100 most commonly prescribed medications right here. They get consulted prior to receiving the medication, or if they have questions, a lot of these make use of telepharmacy. Simply pick up the telephone and the pharmacist live 24/7. When I talk about this kind of stuff, I get a lot of pushback from pharmacists because there's that old mentality that pharmacy still has to touch every drug. And I think as long as we're cemented in that mentality, we're going to continue to struggle as a profession. So now let's assume that we've automated the pharmacy, and the question becomes, what do we do? Well, it's a very good question. We have to go back to the PPMI statement. We have to utilize pharmacists as direct patient care providers. Pharmacists are everywhere in the healthcare environment. I don't think people realize that, but we're in the acute care, we're in the outpatient ambulatory care, community pharmacies. We're some of the most accessible healthcare providers that are out there because we face the public. And you also have pharmacists that work in the pharmaceutical industry, and you have guys like me who have gone to the dark side and actually work for people who build pharmacy equipment, pharmacy software, and that kind of thing. I used to think that the best place to interact with patients was in the hospital. I'm starting to rethink that a little bit. You know, I practiced my whole career before going to work for Talyst. I practiced my entire career in a hospital. And that's kind of where the young pharmacy jocks hang out, right? They hang out in the hospital because that's where the coolest, neatest stuff is. Watching Dr. Simpson's presentation, that stuff is fascinating to me. I think that's just phenomenal. And the only place you're going to see that is in a hospital. But I'm starting to think that from a pharmacy perspective, that is actually a reactive approach to the problem. The problem is actually prior to the patient getting into the hospital. And so I think that's where our biggest bang for the buck is. And what that means is we have to start thinking how to approach this slightly differently. Patients today are a lot more intelligent about their health care than they used to be. They're a lot more involved in their healthcare process. And we have a technology now that we just didn't have in the past. You know, the internet has changed our lives forever, and there's no going back. You know, and how do we know that it's changed our lives forever? Well, we've asked, right? We ask people. I don't ask people, but somebody does. If you go and you look for these kinds of studies and surveys, you can find them all over the place. This one happens to be a recent Pew Internet survey, and it showed that 81% of all U.S. adults are using the internet. It's no surprise. But of those, 72% use it to basically access healthcare information. And what's interesting about this is they're not going to specific medical information websites like, let's say, WebMD or a pharmaceutical manufacturer. They're going to Google. They're going to Bing. They're going to Yahoo. And so we need to take advantage of that, and we need to rethink the way we approach this, because this is offering us an opportunity to engage patients at their level. Because let's face it, sometimes a patient ends up here, they get a little bit of information, and it makes them more dangerous than knowledgeable. They don't have the background information that they need, or they don't have anything to go along with it. And from the same study, we know that patients are going mobile. I just went to grab my phone to show you my phone. I left it on the desk back there, and I feel kind of naked without it. But 85% of adults are basically carrying some form of cell phone. It's not all smartphones, but they're carrying some type of cell phone. 85%, think about that. That is amazing. And they're using that to get online. 31% of them have used their cell phone to look up healthcare information from the device. And if you think about it, it's a matter of convenience, right? They now have this thing in their pocket where they can whip it out and they can Google it. My kids say that 20 times a day. I'll just Google it, Dad. I'll Google it, Dad. There was a time when I said that all a pharmacist had to have to be a good pharmacist was a pencil, a calculator, and the drug information handbook. We used to all run around with a drug information handbook in our pocket, and it was our lifeline, right? You'd whip it out and you'd look at something. Well, that information used to be limited to healthcare professionals, right? And it was always just a little bit out of date. You know, I got my brand new healthcare information book, and the book was already a year out of date by the time I got it. That's no longer the case. Everything is simply a Google search away. It means we have to change our approach. We have to start looking at this kind of technology to engage patients from a pharmacy perspective. And from strictly a pharmacy perspective, that means engaging them over their medications, right? It means looking at medication adherence, medication therapy management. It means looking at the management of chronic disease states where pharmacists can be helpful: asthma, diabetes, HIV. And medication non-adherence or the medication adherence problem is huge. Depending on the study that you read, it's between a $100 billion, that's with a B, and a $290 billion a year problem. Now, that's all inclusive. That's lost medication, lost productivity, readmissions. This is kind of everything. And additional data suggests that up to 28% of patients that receive a prescription never get it filled. And of those that do get it filled, there are studies out there to show that in certain disease states, up to 50% of the patients that get it filled don't adhere to the regimen. So if we were to take a look at this problem, if we were simply to say, let's take that $290 billion number and say it's a load of crap. Let's say we don't believe it. And let's go with the 100 billion, which is the low end of things. And let's say that we could engage the patient and we could get 10% of them to do a better job. You're still talking about a number like $10 billion that it could save the healthcare industry. And this is yearly. Okay? This is something that's repeatable. It can be done every year. And this doesn't just affect the patient. I mean, obviously, the patient is the one who gets hurt by it the most. It leads to readmissions. It leads to increased morbidity. But the hospitals have to clean up the mess, right? You have more visits to urgent cares, more visits to ER. It's a domino effect. And even if you want to think of it from purely a financial perspective, this hurts the drug manufacturers, right? If 28% of them never get their prescriptions filled, that's 28% of the sales they'll never have. And it also hurts the insurance companies who may have to take care of a patient once they're hospitalized instead of them just taking their medication. And there's all kinds of technology that's out there to help us do this. And it can be something as simple as text messaging, right? Text messaging has been studied a lot. And remember that number I told you, 85% of all US adults are packing a cell phone. Even the simplest cell phone that's out there can receive and send text messages. So text messaging has been shown to be quite effective in several disease states, such as HIV, asthma, diabetes. These are heavily studied if you look for the information, in some pediatric populations. And it hasn't been so effective in things like oral contraception. So the study around oral contraception showed that text messages did not increase adherence. You know, I have some theories on why this is the case, why it works in some and not the other. And I think it has to do with the seriousness of the disease state and how invested the patient is in their disease. I would wager that somebody with HIV is very vested in their health care and wanting to take care of themselves. Or you have something like pediatric liver transplant where the parents are involved, right? And oral contraception, you have some very young people who have their minds going in a bunch of different directions and they're getting 10,000 text messages a day from everybody. It's just another annoyance. Here's a study that, this is pretty new information right here. This was done by a group at Georgia Institute of Technology. And what they did is they were replicating a study that was presented in 2012 at a National Informatics conference. And what they did is they took very simple text messages and they sent it to kids, 30 kids ranging from 10 to 17 years old. And they sent them text messages about their asthma. Here's the kicker. They didn't actually tell their patients to take any of their medication. They just asked them, hey, how are your symptoms doing? Or, you know, they would test them on their knowledge of their asthma. And there were three groups. There was a control group that received no text messages, one that received a text message every other day, and then the third group that received some form of text message every day. And after 4 months, the one that received the text message every day had much better quality of life, much better pulmonary function. So it doesn't have to be, hey, take your medication. It's mostly engaging the patient about their disease state in a very simple way. As I said, this is a very simple technology that can have tremendous impact. If you look at the impact of asthma, we're talking of millions of ED visits. Actually, it's around 1.8 million ED visits a year and 1.3 outpatient visits per year related to asthma exacerbation, somewhere around in there, depending on what information you look at. And then, of course, if you have the whiz-bang smartphone, you can get into applications now that do a whole lot more than simply remind you about your medications. This is just one example. This is an application called Mango Health, and it runs on a smartphone. Specifically, it runs on iOS, which is the Apple products. As far as I know, there is no Android version of it quite yet. But this allows patients to set reminders for their new medications. It also checks for drug interactions based on the information that they're put into their phone. And it sends them reminders. But one reason I specifically mentioned the Mango Health application is because it uses this thing called gamification. So gamification is where they integrate the idea of game mechanics into a phone to hopefully engage the patient in what they're doing. You know, everybody likes to play games. You know, I'd wager everybody that has a smartphone in here uses it for one type of game or another. But what Mango Health does specifically is it gives the people points for telling it when they took their medications and when they answered the reminders, and they're able to use those points for things like gift cards at retail outlets like Target, for example, or for charitable donations. So I think this is just a phenomenal idea, especially applied to pediatric patients, where it may make a bigger impact. And then for those of you who like something a little more traditional, there's all kinds of products like this that can be used in the home. There's a plethora of these. This one happens to be the Vitality Glow Cap, and the reason I mention it is because it's probably the one that's been around the longest. It's also the one that's commercially available in retail pharmacies. For example, this one happens to be, was purchased by CVS, so you can get it in a CVS pharmacy. This is, it's kind of cool. So when your medication is due, it lights up, and it plays a little musical tune telling you to take your medication. If you don't take your medication, it sends a message to a secondary light source in the house. If you still ignore it, it calls you, and it tells you to take your medication. If you think about it, this is really well thought out, right? So it gives you 3 opportunities to screw up. And the other thing that is really nice about this is it has a button on the bottom of it for refill. So you push the button, it has a cellular connection to the pharmacy, and it tells the pharmacy that you're due for a refill. Now the reason that's important is, when do people realize that they need a refill? The last pill in the bottle, right? They're taking the last pill in the bottle and like, oh, I need to get a refill. They cap it, they walk away, they get busy doing something else, and they never do it, and then they're non-compliant. Well, with this, when you look in the bottle and your last 2 or 3, you send the pharmacy a message. The pharmacy will call you, say, got it? Are you good to go? Yep, I'll be there to pick it up. So phenomenal little pieces of technology like this to sit around the house. And then this one is another prescription bottle. It's called Adheretech. And they get brownie points just because it doesn't look like a regular prescription bottle. I mean, I don't know how old the prescription bottle is, but man, they need to change that thing. The reason I mention this one is this is a really high-tech piece of equipment right here. This has a small battery in it, so it's Bluetooth connected. Inside the walls of the bottle is capacitive technology, much like you see in touchscreen computers. So it's able to measure the quantity of tablets or the volume of liquid that's in the vial at any given time. So in real time, you, the provider, a healthcare provider, a family member, a friend, can look in there and actually see how much of something you have left. The other thing that's important with this, if you think about the fact of, let's just put it real quickly in the perspective of an overdose. If somebody took all of these medications, it could alert you that, you know what, 30 of those tablets just disappeared. Where did they go? Did you dump them? Did you flush them? Did you take them? What happened? So this technology is under development. It's being kind of beta tested, but it's just, the idea of it is phenomenal. The other thing, and for the IT people in here, this is one of the first of its kind, it offers an application programming interface, or an API. What that means is that smart people like you will be able to write programs to interact with this so that it can be connected to things like electronic health records. It can be connected to insurance companies. It can be connected to gamification systems like the Mango Health app I just mentioned. So this is something that is extremely important and something we don't do enough of in healthcare. And of course, this wasn't developed by a healthcare company. This was developed by a couple of guys in their garage that thought it would be cool. And then, of course, for specific disease states, there's a ton of this stuff out there as well. This little ditty right here is called the GeckoCap. It was thought up by some IT physicians, pediatricians, and some engineers and some designers over at IT. And it's a little bitty rubber cap that goes on top of an existing inhaler. And it has a small LED light in it. And the LED light flashes until you take your medication. And it's connected via Bluetooth to a web portal that records the information. And actually, it has a very nice dashboard. It shows how you've been doing in terms of your scheduled inhalers, and it also has a place where you can do rescue medication, where it documents your rescue medication use, and you can put in reasons why, or why you've taken extra doses or why you've missed doses. And the other nice thing about this one is that it also has this little gamification tied into it for the parents. The parents can go into the system and create rewards for the kids for sticking to their medication regimens, and that's totally up to the parents what that is. But what that does, hopefully, is it engages the kids. Whether or not rewards are the best way to go, that's a debate that's in healthcare. And so I don't know what that is, but this offers it. As Mapleus, By the way, it took me a long time to figure out how to say that as Mapleus. It's another inhaler piece of technology that goes on top of your inhalers, but it's different than the GeckoCap in that it records, it doesn't remind you when to take your medication, but it records when and where you took your medication. So it uses geotagging to find out where you are, so you can look at that information and tell where you're having your problems. And what's beautiful about this kind of thing is they're leveraging this aggregate data to look at asthma patterns throughout cities. So if you took 1,000 people using their inhalers and they had the ability to geotag, you would have these incredible bits and pieces of information that you could map out in cities to see where you're having your problems, see where certain people are having their issues, see what days are the worst, what days are better. And it's phenomenal technology if you think about it. And that's just the tip of the iceberg. I mean, this type of technology is being developed every day. If you spend any time on the internet, you know that one of these is popping up pretty much every day. And now there are incubators out there that do nothing but encourage this kind of thing with funding and development. And we have hacking sessions these days where people get together and just think stuff like this up. But you have blood sensor monitors, you have things that are embedded in the tissue. There's even digital tattoos now. I mean, what we can do with this technology is mind-boggling, but it creates a problem. And that problem is, in healthcare, we have no way to deal with this information. So the amount of information that is coming from the mobile revolution is mind-boggling, right? And in healthcare, we have very cutting-edge technology for 1980. We're struggling to keep up with what to do with gobs and gobs of information that need to be fed to us in a centralized location where we have easy access to it, right? So that's it. We need to have a centralized location where all this information comes in and we all have access to it. Simple. Well, it's not so simple. We're struggling with it. We're struggling with it in a bad way. But there is a template for this kind of thing out there, and it's mind-boggling to me that we've never taken advantage of the template. And that, of course, is social media. Now, I'm not saying use social media. I'm saying social media has developed a template for how to handle this massive amount of information that comes in from all kinds of separate, very distinctly different systems. Now, people tell me all the time when I bring this up and I have this conversation that healthcare is different. Well, sort of. We're different, but we collect a lot of the same type of information, right? If you want to collect images or photographs, there's social media out there to do that. If you want to collect, watch, archive, download, upload video, there's systems out there that can do that. If you want to write free text, narratives, engage with people, there are systems out there to do that. And these systems here integrate these systems into it. If you were to look at something like Facebook, apparently Facebook is no longer cool, I've been told by my kids, okay? But I am on Facebook, and I'm amazed at the timeline. I go in and I look at my timeline all the time because it tells me what I've done, when I did it, and who I did it with. And it's right there. And it's broken down by year, by month, by day. I mean, if you think about it, that's the type of information in healthcare that we would love to have. When did a person do something? How did they do it? Who were they with? What was it associated with? And if you think about the fact that these are now becoming digital wallets, so you have Google Wallet, and you have the iPhone has Passport or Passbook now. And so every time you make a purchase, ding! So your diabetic patient, just bought a apple juice and a donut, right? And then you see this huge spike in their blood glucose monitor, and you go, there you go. So that's the type of information that we would love to have access to. And guess what? It's right here. It's in social media right now. And literally, these are guys that are sitting around in their garage and went, you know what, I think we should make something. And they do. These are the guys we should be talking about. If you look at the numbers, it is absolutely staggering. As of January of this year, Instagram, which seems to be about the most popular social media platform for photographs, has 90 million active users. Okay, 40 million photos are uploaded every day to that system. This is something that's freely available. You go download it, you just start using it. You can follow people, you can look at people, you can take their photos, use their photos, share their photos. It's amazing. Google Plus. Google Plus is the newest of the social media platforms. It's been out less than 2 years. It's already the second largest social media platform, second only to Facebook. There's about 343 million active users on Google Plus. Now, here's the thing about Google Plus. It's tied into Google. Go figure by the name. It's tied into Google. So it tracks what you do. It tracks what you search. It allows you to post comments, photos, video. It allows you to have Hangouts. A Hangout is where you go and you start up your video camera and you interact with whoever wants to join. Now, you can lock people in. You can lock people out. You can set up communities, and by setting up communities, you can limit who gets to see your data, who gets to access your data. This is what we're looking for. And then the coup de grace, the granddaddy of them all is YouTube. These numbers fascinate me. YouTube has a billion unique visitors globally every month. 4 billion hours of video are watched every month, 4 billion hours. I mean, it's hard for me, I can say it, but it's hard for me to comprehend what that means. 72 hours of video is uploaded every minute. 1 minute, 72 hours. Another minute, 72 hours. And here's something just to note, 25% of this is done on a mobile device, a cell phone. So something to think about, a template for the future maybe for healthcare is right here, but it's interesting because this is right now. And in our current healthcare model, we'll get there in about 10 years. But then there'll be something else. Now, there's a big concern over privacy and security, and this is where I'd like to call them discussions, but they're more like arguments when I start talking to people about this kind of stuff. Should we worry about security and privacy? Absolutely. There's no question about it. We should have things in place to make sure that people's security and people's privacy are maintained. But should it stop us from moving forward and looking at new technologies? The answer to that is no. I'm a huge proponent of cloud-based storage and the use of the cloud. And the reason is because I'm one of those guys that just has a ton of toys around the house. I have Windows machines, I have Mac machines, I have a Chromebook, I have Android tablets, I have an iPad, I have a new Windows tablet, a Windows 8 tablet. I'm all over the board, and I hate having to move files around, so I store all my stuff online, and I don't worry about it. When I go to get something, it's there. And I think that is fairly safe. People will argue with me that it's not, but let me ask you this. Our current model utilizes paper records, fax machines, and laptops. Is there a week that goes by where you don't read something about a laptop that was stolen, lost, or taken that has hundreds, if not thousands, of patient records on them? The answer is no. So something to think about as we move into move forward. Security and privacy definitely needs to be dealt with, but it shouldn't prevent us from looking at new technologies. You know, what's that mean for the future? Man, I have no idea. That's the problem with the future. It hasn't happened yet, right? If I could predict the future, I'd be sitting on a beach having a Diet Pepsi right about now. But the fact of the matter remains, there are a few things that I think are going to change the way we practice pharmacy in the future, but it's not mobile health. And the reason it's not mobile health is because mobile health care is now. It's not the future. If we start planning for mobile health being the future, we're going to be a step behind. I think, for lack of a better term, photo analytics and augmented reality are going to be big for pharmacy. This is an application called MedSnaps, and what it does is if you take a picture of a tablet, the application takes it, does some magic with it, and says, oh yeah, that's a Tylenol tablet, and here's the usage and the directions and the guidelines. Now, it's not perfect. It requires a small secondary piece of technology, but that's the direction we're headed. There's another company in Quebec that is doing this with syringes. So if a nurse pulls up a syringe, it uses edge detection to tell you the volume of the liquid in that syringe. This is where we're headed with that kind of technology. And then augmented reality. Augmented reality is one of those things that it sounds just neat and cool, but it actually could be helpful because it can tell you what's going on when it identifies something. You don't have to reach out and tell it what you're looking for. Now, where this comes to significant value to us is that you could possibly connect this in the future to smart glasses. You know, Google Glass is all the rage right now. If you go on the internet and you look, you can find just a ton of information. Go read yourself silly about it. But what this does is this leads us to the next step of the evolutionary process, which is to get away from this. Information is here. And a lot of people wear glasses already. I do. A lot of people do. But it's probably headed down the road to contact lenses as well at some point in the future. But I actually think that this type of technology is going to be more useful for patients than it will be for healthcare providers. So think about prescribing the use of something like smart glass to somebody for medication adherence. Hey, take your meds. Or think about prescribing this to somebody who has a memory problem or a dementia patient, right? You can send them reminders straight to their glass, or it can monitor those patients and tell you what's going on. Just phenomenal technology. Subdural sensors. Now, what's really cool about this one is this has 5 sensors built into it already, and each sensor is covered with a different enzyme, and that enzyme is custom built to monitor whatever you want. It could be a drug, it could be cholesterol, it could be glucose, it could be anything. It has a small patch that goes over the skin to power it, and it can stay running for several days to weeks. They're heading for a month. Now, where I find value in these is preventative medicine mostly. So let me give you a quick story. My mother was diagnosed several years ago with a very rare form of an autoimmune disease that destroyed her liver. And she was on a lot of anti-rejection type of medications, and one of those was tacrolimus. And due to a prescription error, she received a 10-fold overdose of tacrolimus for about 7 days. Anyway, she ended up in the hospital for 8 weeks. 6 of that was in the ICU at UCSF on a ventilator. Acute renal failure. She was on dialysis for several months following. She has since got her liver, and she's doing just fine. Tough lady. But this would have prevented that, right? And not only in the damage it did to her and the mental torment, but the cost. The cost of that 8-week stay due to a med error would have never happened if somebody would have been continuously monitoring that drug level in her blood system. Nanotechnology. These are little miniature TIE fighters that run around your blood. And some of this technology is actually out there in phase 1 trials, and it's phenomenal. Antibiotics that attack specific antigens. And my favorite is one that is a small nanobot, nanobullet that's built of gold. It has a DNA scaffolding. They load it up with chemotherapy. They send it to the tumor. They light it up. The DNA breaks apart, delivers the chemotherapy. That's just phenomenal. Decreases the side effect profile of the drug, still get the efficacy at the site. Smart insulin, where you inject the insulin measures the blood glucose, decides how much insulin you need. I think this is where we're headed. This is going to change the way that we practice with medications in certain disease states in the very near future. And then finally, pharmacogenomics. This is one of those things, when I got out of pharmacy school, they said this is going to change the way you practice. Well, that was 16 years ago, and it hasn't happened. But we're starting to see it in other places now. And this will be of tremendous value for certain high-risk populations of patients who have variation in their genetic enzyme structure, where we will know when they enter the hospital whether a certain type of product will work for them or it won't. And if you're interested in that kind of stuff, this gentleman here, Stephen Tucker, he's worth following if you're on Twitter. And he talks about pharmacogenomics a lot, and there's a bunch of guys just like him. Actually, if you want to do anything on Twitter, there's always somebody out there in the social media space that's talking about exactly what you do. I wish more people like Dr. Simpson had the time to engage at that level, because what it does, it gives us an opportunity to talk to each other. It doesn't matter where we're at. I've had some great conversations about medication therapy with physicians in Europe and New Zealand and Australia, and the only way I can do that is through the use of social media. And so what does it all mean? Well, it means that pharmacy practice right now is on a death march. If we continue if we continue to do exactly what we're doing right now, the practice won't exist in 20 years. It'll be past my time, but the new pharmacists coming out of school will have nothing to do. We need to continue to advance the technology to completely automate the distribution process, and we need to take the pharmacist and carve them out of that, and we need to move them out to engage the patient using the existing technology that is out there today. And if we don't do this, then we won't be talking about this 20 years from now, because the profession will unfortunately probably be dead. It'll be obsolete. And with that, I'll take any questions that you might have.
So questions? I love the drug bot thing. Swallowing gold.
Jerry, excuse me. I've been in pharmacy technology for like 23 years. That was a great, brilliant presentation. Good stuff. You didn't mention Proteus Biomedical. They just got like $45 million in VC. kind of an ultimate adherence monitor, the ingestible technology. But I look at it and see kind of supply chain problems. Do you have any comments on
You see what? I'm sorry.
Problems with the supply chain?
Oh, yeah. You know, anytime you have this type of new technology, you're definitely going to see that problem. And I know what you're talking about. I actually had a slide for that. It's been approved and it's being used in the UK, the Proteus tablet. The Proteus tablet, you swallow it, it has a patch, and it continually sends data to the patch that you can monitor. Let me give you an example, though, about supply chain. If you look at companies that have made great use of supply chain, it's not in the medical industry, it's actually in the private industry. Apple, for example. You know, I don't use Apple products per se, but Apple has done a tremendous job of their supply chain, as has Samsung and other companies like that. And we need to learn from those companies. We need to make sure that we secure the raw ingredients, which sounds crazy, but with drug shortages, that's what we're hurting. We're hurting with raw ingredients. So we need to make sure that we secure those when we start talking about this type of technology. So when you think about involving a group of people, you have to make sure that you're talking to not just the people who have ideas. You have to talk to all the people that might be involved in the process, and it'll be like running a company, right? You're going to have people that are in charge of logistics. In this case, it's huge. You're going to have your engineers, and you're going to have your testers, and you're going to have all that. So healthcare needs to take a look at companies, in my opinion, like Apple and Samsung, and see how they're doing it. We can learn from that.
Hello, my name is Ruth Owoshika, and I just graduated from USC 2012 pharmacy school.
Congratulations.
And my life just flashed before my eyes, because you just said we're not going anywhere in 20 years. But I really wish she could come and speak to the students, or if I ever had a professor like you to really inspire the future. We'll talk after, but moving forward, how do you integrate, okay, basically we had a lot of classes on pharmacogenomics. How do you integrate such technology while managing costs, especially with the Affordable Care Act, and then you put all these magnificent devices? I could just only think about healthcare disparity. Like, who would really have access to all of this but the rich?
First of all, your question is being debated by organizations like ASHP right now. That's being talked about at that level. It's a good question. Not everybody is going to have access to this type of information. It's unfortunate, but it's true. But remember, even some of the simplest technology that is out there can be used to change. A phone call has been shown to improve medication adherence. A phone call. You give a patient a call and say, how you doing? It's been shown to improve medication adherence. The other thing is, I don't think we have blinders on in healthcare, and we see immediately this is going to cost too much, but we don't look over here and say, yeah, it cost us a bunch right here, but it saved us a truckload over here. And I think if we do that for a minute and we start looking at the cost savings down the road, again, unfortunately, it's the only analogy I have, like companies do today. Companies are willing to go in the hole now for 10 years down the road. I think then we'll be much better off. And I think that's the answer right there to, the cost of it. The cost of it is high now, but not implementing it, the cost is even higher. All right, well, thank you. Oh.
Another question?
Just a real quick, you mentioned the like Google Plus and all. Are there any companies out there starting to pull together something?
There are a couple. Dr. Chrono is one that I find very interesting, and it's a startup company. And here's the thing, these things are free. Dr. Chrono is a company that's doing something like this, and there's also another one called Practice Fusion. They're out of the Bay Area, and they're doing some of this stuff, but their problem has been getting connected to the information, which is our issue, right? We can't connect them, but they're doing work like this. So there are companies out there doing it, but they're struggling. It's not the limit of their technology, it's the limit of ours.
Okay, we have another question over here.
A great presentation.
Thank you.
All these technologies that you talked about, as you mentioned, we are already 10 years behind Walmart, Amazon, when we talk about the supply chain, everything. But how do you recommend new hospitals or new healthcare facilities having the infrastructure to implement some of these? Because we have to have it first in a hospital and then in the social media and everything. And
Right.
some hospitals currently don't have the proper infrastructure to implement any of these systems.
Okay. The answer to this is kind of political minefield. Anybody in the IT department, plug your ears. In healthcare, we have to stop hiring people that have grown up in the healthcare system. We have to start hiring people from outside the healthcare industry that are thinking and doing things like this. And it's that simple. We won't build the infrastructure because we just don't know how to do it. These people, they know how to build the infrastructure. And unfortunately, that's the answer.
Thank you. Any more questions? I just know that the prompt for me for taking my medication in the evening is using pet therapy. I put my evening medication next to my dog's medication. She always reminds me when she needs to have her evening meal. So good thing for pets. Thank you so much.
Thank you.
So we're going to have a break. And I want to remind that we have a wonderful exhibitor hall next door. Since we had a little bit of a break this morning, I'm going to carve out just about 5 minutes